Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Recently, ICOS sponsored a webinar focusing on risk stratification of cancer patients with a particular focus on recent guidelines produced by the European Society of Cardiology and the International Cardio-Oncology Society. Today, we present a highlight from that webinar. We are fortunate to have Dr. Blaes discussing how to risk stratify patients treated for cancer more than 5 years post-treatment. Dr. Blaes holds the B.J. Kennedy Chair of Oncology at the University of Minnesota, where she is the Director of Cancer Survivorship Services and Translational Research. Don't forget to visit the renovated ICOS website, where you can find information on all topics related to cardio-oncology, including survivorship. So for now, please enjoy this presentation by Dr. Blaes.
My name is Ann Blaes. I'm a professor and an oncologist at the University of Minnesota, where most of my research really focuses on cancer survivorship. And so today I'm going to talk to you for a little bit about how do you risk stratify the cancer patient treated more than 5 years ago, thinking about the long-term survivorship period. So I'm going to start with a case presentation, and Danielle and I didn't do this in exactly the same way, but our patients actually ended up very similar. So in this case, the 60-year-old who comes in to see you 5 years after being treated for breast cancer, she had a stage 3 left-sided ER-negative, HER2-positive breast cancer, received a similar course of treatment, THP with a taxane, trastuzumab, and pertuzumab, followed by adriamycin and Cytoxan. She achieved a pathologic complete response. Her ejection fraction was 60% at diagnosis and remained stable during the course of treatment. Went on to have a lumpectomy, left-sided breast radiation, and adjuvant trastuzumab pertuzumab therapy. She has diabetes and hypertension. She has peripheral neuropathy and pain with walking, and she complains of fatigue, decreased physical performance status, as well as stresses on her family from her inability to work as much as prior to her cancer diagnosis, plus bills from her treatment. So how do we think about the cancer survivor who's coming back into clinic, whether that's to see the cardiologist, the primary care provider, or the oncologist? And I think about this in a couple different ways. First of all, what's facing the cancer survivor who's no longer on treatment is really thinking about cancer recurrence risk. How likely are they to develop metastatic disease? What is their overall cardiovascular risk? What other comorbidities are impacting them? And how do all of these factors contribute to quality of life? Many of them are suffering, as you can see through the diagrams, from things like peripheral neuropathy, symptom management like cognitive dysfunction, fatigue. They've lost physical function. In addition, many of them are going through financial stresses or changes in job responsibilities. So in thinking about breast cancer recurrence risk related specifically to our patient here as an example, in the oncology setting, we're using more and more therapies in the neoadjuvant setting. And what I wanted to highlight here is in the figure on the left, those who achieve a pathologic complete response, even when they present with more advanced stage disease, do extremely well. So the PCR rates for those, even with stage 2B disease, over 90% of these patients in follow-up periods will have a long-term survival without breast cancer recurrence. In the figure on the right, this is actually risk stratified, and these graphs are slightly different depending on which subtype of breast cancer that they have. The one that's circled there is really the estrogen receptor negative, HER2 positive breast cancers. For a patient like this who had a complete pathologic response, their overall survival and their disease-free recurrence is over 90%. So really we're talking, while she might be seeing you worried about cancer recurrence, we really have to be thinking about how to support all of her and not just thinking about cancer recurrence, but also her cardiovascular risk. And why is this actually important? Many of you may be familiar with the paper that was published by Strongman and colleagues in JACC Cardio-Oncology last year, where they really they looked at an English retrospective cohort using EHR data and looked at CV mortality. In the follow-up periods in the graph on the bottom of the slide, what you'll see is with time from a cancer diagnosis, primary malignancy or any cancer decreases over time, but cardiovascular disease increases with time as individuals are aging, and particularly for our older individuals over the age of 60, and particularly in those over the age of 80, this actually surpasses their cancer mortality. We heard a little bit from Dr. Cardinale about a patient such as this cardiovascular risk. So I'll kind of quickly just go through this and not repeat it based on time. So we have some time for discussion. When she originally presented, we know in this case she had hypertension and diabetes. And this is a risk factor both for anthracyclines as well as HER2 targeted therapies during the course of treatment. She was told that she had medium risk factors with the receipt of these, and as a result, at baseline, underwent EKG, troponin, BNP, as we heard very eloquently from Dr. Cardinale, as well as imaging. But what about in the survivorship period after treatment? These are two additional cohort studies that really look at the fact that most of our cancer survivors are actually at higher risk for dying from their cardiovascular disease. And in the figure on the right, this is a Long Island breast cancer cohort, which really demonstrated that CV mortality surpassed that of the general population 7 years after diagnosis. In this older cohort study looking at the California population, by Sarah Armenian, they looked at 110,000 patients with those controls with common cancers. And you can see cardiovascular disease was more prevalent and affected mortality, both in those with and without CVD. So coming back to the risk stratification and thinking about the survivorship period, in the first year after therapy, based on the ICOS guidelines and the ESC statements, as we've heard, we really think about clinical characteristics, CV imaging, such as TTE, and then biomarker risk stratification with the use of troponin and BNP. I think this is a unique opportunity to really be thinking about education of cardiovascular risk factors for our patients when we're seeing them in the clinic, and really risk factor control, controlling hypertension, diabetes, lipids, as well as talking about tobacco cessation. And many of these patients are seeing oncologists, some are seeing primary care providers. And so education is not just about us with our patients, but it's also thinking about our colleagues. What about the cardiovascular risk stratification in the survivorship period? Based on the ESC guidelines that were just published, these are considered high-risk conditions for future cardiovascular risk at the completion of treatment. So we go back to those baseline risk assessments, as we heard earlier from Dr. Cardinale, as well as I showed you briefly in this particular patient. We think about specific factors that are associated with long-term cardiovascular complications. This includes doxorubicin over 250 milligrams per meter squared, radiation doses of over 15 gray for median heart dose, or a combination of these at lower doses. There are some unique patient populations, such as high-risk stem cell patients, as well as those who actually developed cardiovascular dysfunction during their cancer treatment, or anybody presenting with new symptoms or present with abnormalities involving echocardiogram or cardiac serum biomarkers at the end of their treatment. In this case, thinking about this particular patient, they would have received 240 milligrams per meter squared of doxorubicin, as well as had left-sided breast radiation. And in many of them, like this patient here, we don't know what the median heart dose is. They were treated at a time that was not part of their records. We do know this risk is increased, though, with her having left-sided breast radiation. So coming back to thinking about this patient in the survivorship period based on the ESC guidelines as best consensus, a patient such as this individual who received left-sided radiation as well as anthracyclines would be considered at high risk for long-term complications from their cancer treatment. And as such, the guidelines recommend a TTE at years 1, 3, and 5 after cancer treatment, and then every 5 years thereafter in adult cancer survivors. We talked a little bit about patient education as well as the cardiovascular risk factor optimization. And I wanted to just highlight, how does this compare to other guidelines? So ASCO's guidelines, their cardio-oncology guidelines, are now several years old. But many in this situation would also recommend that in asymptomatic individuals, an echo be performed 6 to 12 months after therapy. They did not have ongoing recommendations about the duration or frequency of imaging in patients who are asymptomatic. And so as a result, I really think with the updated guidelines from ESC, thinking about how do you risk stratify, and in this case, with the patient having both anthracyclines as well as radiation, ongoing imaging every 5 years would be reasonable and appropriate. How does this fit into the whole picture when we think about a cancer survivor? We have underlying cardiovascular risk, as we've mentioned before. We heard from Dr. Cardinale about treatment-related factors and risk factors going through treatment. And then in the survivorship period, thinking that many of these patients are also undergoing impairments in physical function as they've gone through the aging process and impacts from the cancer treatment. Many are undergoing and working with social work and spiritual health to keep themselves functioning well. And in some of these situations, they will be diagnosed with another cancer, taking them back through this cycle. There are some unique situations. I won't go into detail with them for the sake of time, but recognize that our screening for pediatric and adolescent young adult cancers is more frequent. Any of those patients who have more than 100 milligrams per meter squared or have any radiation to the chest need ongoing surveillance. And I recommend you look at the ESC guidelines as well as the International Harmonization Guidelines. And in some cases, our cancer survivors are pursuing pregnancy after cancer therapy. And for those who've received anthracyclines or have had chest radiation, they also need aggressive risk stratification. I mentioned the impact of physical function on cardiovascular assessment and wanted to just reiterate the statements from AHA on cardio-oncology rehabilitation, recommending that patients should be getting out 150 minutes of exercise, moderate intensity throughout their survivorship period. For those who have had anthracyclines or trastuzumab and have cardiovascular risk factors, a core or rehabilitation is oftentimes a really important part of their survivorship period. We know that when we talk about diet and exercise and sleep, these factors actually improve overall survival for our patients. In the figure on the left, this actually looked specifically at the EPIC study, which looked at cancer and nutrition in 13,000 breast cancer cases with a median follow-up of 8.5 years. And individuals on a low inflammatory and a diabetes risk reduction diet had improved overall survival. This was replicated in the PLCO study, looking at 1,000 breast cancer survivors, suggesting that diet is important for overall survival as well as potentially for cancer recurrence. When it comes to exercise specifically, the STORM cohort is a cohort actually of metastatic breast cancer, but suggesting actually that those getting moderate to vigorous physical activity have improved overall survival. This has also been seen in the curative intent setting in an Australian cohort called Exercise for Health trials that looked at a randomized trial of 8 months of progressive exercise intervention showing improvements in cancer recurrence as well as overall survival. So if we come back to our patient, this is a 60-year-old who has risk factors, diabetes and hypertension, received anthracyclines and trastuzumab as well as left-sided breast radiation. And this, based on guidelines and best consensus, would put the patient at high risk for long-term cardiovascular-related dysfunction. So from a risk stratification, ongoing cardiac imaging would be recommended at least every 5 years with reevaluation of cardiovascular risk factors. Aggressive management of cardiovascular risk factors. We discussed some lifestyle risk factor management. And if any asymptomatic changes occur in imaging, to consider cardio-oncology referral. So in conclusion, our best consensus guidelines by ICOS really exist to risk stratify cancer survivors for cardiovascular surveillance after cancer treatment. Most of this risk stratification is based on anthracyclines, radiation, as well as risk factors or changes in biomarkers and imaging at the end of treatment. And I didn't go through the details here, but if you look actually, 98% of cases are detected within 12 months at the end of treatment when you look at least some small studies of those who go on to develop cardiovascular-related dysfunction. And I think it's important to highlight, as I've seen in the chat actually come out, is that there do remain some gaps in research. We still need to understand the large spectrum of potential toxicities when it comes to new therapies, such as immunotherapy, the cost effectiveness of the screening, as well as recognizing the impact of disparities on cardiovascular screening and long-term health. And finally, I think there remains a gap in the implementation of this risk stratification. And for any of you who are really interested in this topic, this is something that I've worked on with a group of individuals and are hosting a conference out at Stanford in September. This is hybrid. It is an international meeting, really looking at the practical implementation with members from ASCO, the Australian COSA, as well as the NCI.
Such an outstanding presentation focusing on a very human and comprehensive approach to all aspects of cardiovascular risk in cancer survivorship. Please check out the ICOS website to find more educational material like this, including a calendar of upcoming events. Thank you for listening, and on behalf of ICOS, this is Dr. Tom Murtaugh reminding you to treat cancer, protect hearts.